So, dear students, it's once again a great pleasure to come back to you and talk to you on a different topic from respiratory system. We are now moving on to a topic in the gastrointestinal system, dyspepsia, a very, very common topic that we encounter in our clinical practice. There is a paradigm shift in the understanding of dyspepsia, and I'm going to take you through the latest guidelines on how to evaluate and manage dyspepsia using an algorithmic approach. Be attentive and let us see how we do it. And of course, this talk is available on my YouTube link. It will be made available, and on the website, of course, the PowerPoint presentation is available. Okay. Dyspepsia, an algorithmic approach. And we are using here the guidelines from the National Institute for Clinical Excellence. NICE UK is the National Institute for Clinical Excellence. They keep on publishing guidelines on various topics of clinical interest. And these guidelines are on dyspepsia. You can see here a 228-page book is there. And this book is the one which is used here as a quick reference guide. Okay. Management of dyspepsia in adults in the primary care. This is from the UK. Now, just sink in with these ideas here. Think a while. The patient walking into your chamber, and then you have to know, what am I dealing with? Is it cancer of the upper GI tract? Should I not look for H. pylori? Is it drug induced? Are there NSAIDs being induced, being the cause of the dyspepsia? And what is the modern management? These questions should go around in your mind. What am I dealing? Is it cancer? Should I look for H. pylori? Is it drug induced? Probably NSAID, commonly used. And what is the modern management? Okay, these questions should go in your mind. When we were students in the 20th century, what we were seeing are carcinoma of the stomach, peptic ulcer disease were very common. And in the operation table list, we used to have in the theater peptic ulcer related surgeries, GJ vagotomy, gastrectomy, vagotomy, like that. Luckily, peptic ulcer disease has come down by the end of 2000, as well as the gastric cancer. There is a very sharp reduction, but that place is taken over by functional dyspepsia and GERD. These two terms, I tell you, are not known to those students when I was a postgraduate or a student, medical student. We don't know a term called GERD or functional dyspepsia. And these are the diseases of the 21st century. What did we learn from this slide? So the upper GI diseases, predominantly gastric cancer and peptic ulcer in the last century or more, have been replaced by GERD and functional dyspepsia related upper GI diseases. But nonetheless, a small proportion of people do have peptic ulcer and gastric cancer too. That is the reason we have to be very careful. We don't want to miss the elephants like the cancer and the process of evaluating a patient. Okay. Then you need to define what is dyspepsia. Supposing I have heartburn for 2 days, I can't call it as dyspepsia. The symptoms must be there at least for 4 weeks duration. 4-week duration symptoms and features of the upper GI origin. Okay, pain induced or worsened by food. And 40% of the adults in a lifetime have this sort of disorders. Generally benign and promotes self-care. They get some antacids or ranitidine and eat and be happy. Symptoms, remember, are poor predictors. A patient may be very heavily symptomatic, but may not have a serious disease. Another patient, symptoms are very mild, he may be having gastric cancer. So you cannot depend on the symptoms as the predictors for the diagnosis. Okay, but then they're important. Okay, you have to use a broader definition. So what does this tell me? This slide, dyspepsia is a chronic condition, minimum of 4 weeks duration. Upper GI symptoms must be there. Pain must be induced or worsened by food, relation to food. And majority of the adults do have dyspeptic symptoms, generally benign. Symptoms may not tell me the severity of the disease. So when I say dyspepsia, hereafter, these are the things that you need to keep in mind. And I'm going to tell you another very clinically important thing. A patient walks into your room, patient has got 4-week symptoms, upper abdominal symptoms, pain related to food, and he is fit to be called a patient of dyspepsia. Then immediately does he have the alarm signs? What are alarm signs? These are the alarm signs. I make it as mad blow. What is this mad blow? This is something like a mnemonic for you. M, mass in the abdomen. A, anemia, unexplained anemia. D, dysphasia, not dysphasia. Dysphasia is speech difficulty. Dysphagia, BL, blood through the mouth or in the stool, and loss of weight, LOW, loss of weight. Okay, mad blow. Remember the word, the mnemonic mad blow. Mass in the upper abdomen or abdomen per se, anemia unexplained, dysphagia, blood in the vomit or in the stool, and unexplained loss of weight. Okay, M, mass in the epigastrium, A, anemia, D, dysphagia, B, blood in the uh, persistent vomiting may be there, and then of course patient may be of any age, GI bleeding. This is blood, and then progressive weight loss. So remember the word mad blow. So what is dyspepsia? Anything upper GI symptoms related to food more than 4 weeks or qualification for dyspepsia. Then the immediate next question is, are there alarm signs or symptoms? What are that? Mass in the epigastrium or upper abdomen, and then A, unexplained anemia, D, dysphagia, difficulty in swallowing, BL, blood in the vomit or in the stool, LOW, loss of weight, and patient may be having suspicious barium images, and age may be anything. Here, age is an important factor. You see more than 55 or less than 55. That we have to look into. Now, what are the symptoms? There are certain symptoms which are related to the dyspepsia of the stomach. Certain symptoms are related to the reflex or GERD, gastroesophageal reflex. They're overlapping, but at the same time, there is some distinction between reflex and dyspepsia. Okay, abdominal pain, you get here acid regurgitation, bloating sensation of the abdomen, heartburn, nausea in dyspepsia, epigastric pain and reflux disorder may be mistaken for heart disease. Early satiety in dyspepsia, patient says, I take this much, sir, I feel very full. Early satiety. And then burping may be a feature of both. And borborygmi, intestinal sounds in dyspepsia. Water brush is a feature of reflex. What is water brush? Suddenly a jet of saliva comes into the mouth. when the patient is talking or chewing or gulping. And that is called a water. And reflux disorder is associated with dysphagia due to involvement of the esophagus. So I contrast here the symptomatology of dyspepsia and reflux disorder. Dyspepsia, abdominal pain, bloating, nausea, early satiety, burping, borporic mind. A reflux disorder is also a component of dyspepsia, but has got a specific meaning. That means patient is experiencing the acid reflux into the lower esophagus. There is acid regurgitation. Patient says, I am getting acidic regurgitation. Okay. And then heartburn, burning on the substernum, epigastric pain, burping, water brash, and difficulty in swallowing. Okay. This is based on a study, a large study, endoscopic study of simple dyspepsia. Look here, 30% are chronic gastritis, another 25% are GERD, 18% are hiatus, and no significant lesion, 16%. Gastric malignancy, 3%, duodenal ulcer, 6.5, gastric ulcer, 3.3. What does this tell me? The commonest cause of dyspepsia is gastritis and GERD. But there is a 3% chance of malignancy and a 10% chance of ulcer. I don't want to miss these two people. That is the whole story of today's presentation. Don't dub it as gastritis or reflux. It may be malignancy, 3%. It may be an ulcer disease, 10%. And it may be hiatus in 18%. That is what I wanted to know. Okay. So the differential diagnosis of these symptoms, the various types of dyspepsia, we need to differentiate them. I'll come to that a little while later. UID, uninvestigated dyspepsia. All these are internationally used nomenclature. Uninvestigated dyspepsia, NUD, non-ulcer disease, GERD, gastroesophageal reflux disease, PUD, peptic ulcer disease, CA, carcinoma of the upper GI, FD, functional dyspepsia. We need to differentiate them because the management of these things is very different compared to these. Okay. Uninvestigated dyspepsia, and then non-ulcer disease, gastroesophageal reflux disorder, peptic ulcer disease, carcinoma of the upper GI tract, and functional dyspepsia. It very much simulates ischemic heart disease. That will be a differential diagnosis. People with COPD, they are more prone for dyspepsia. Okay. COPD, when a patient comes with COPD, he has got upper GI symptoms. You treat the COPD, dyspepsia disappears. You quieten the dyspepsia, COPD becomes better. Liver and biliary diseases like acute cholecystitis, gallstone pain can be a differential diagnosis. Pancreatic diseases and bowel diseases also form a part of the differential diagnosis. Again, differentiate various types of dyspepsia. And do not forget to take an ECG and exclude cardiac disease. Look for liver and biliary disease and look for pancreatic disease. Ascertain whether the patient is having COPD. Okay. So, in the management of any disease, there will be general measures and there will be specific treatment. What are the general measures here? Healthy lifestyle, healthy eating habit. Lifestyle advice goes a long way in the cure of dyspepsia. What are they? Number one, weight reduction. A. B. Smoking. C. Avoid precipitating foods like coffee, chocolate, fatty food, alcohol, sweets. Remember, not the hot. The sweets will have a lot of fat, and that fat irritates and produces dyspepsia. And also raising the head end of the bed or keeping the patient in the left lateral position. Having the main meal 2 hours before going to bed, and slowly reduce the drugs dose of proton pump inhibitors and H2 receptor antagonists. So what are my general measures? Lifestyle advice, healthy eating habits, weight reduction, smoking, avoid precipitant foods like coffee, chocolate, fatty foods, sweets, and alcohol, of course. Raising the head under the bed and keeping the patient in the left position so that the contents of the stomach do not gravitate into the esophagus. Having the main meal at least 2 hours or more before going to bed. This avoids acid reflux and also slowly try to reduce the drugs. These are the general measures. Now, earlier when we were students, hurry, worry, curry hypothesis was there. Somebody who is anxious, who is already worrying, who is always catching with the time and who eats a lot of spices. This hypothesis has been negated. It is no more tenable. And also previously we used to say spicy food and dyspepsia. No, alcohol, chocolate, fatty food. These are the, as I have shown you in the previous slide, coffee, caffeine. These are the irritants, not spicy food. Because the spicy food is dangerous because again it is fat laden and not the spice. Frequent small meal theory. There used to be a theory patient should eat 6 times, small quantity. No, that's not the treatment now. And long-term use of PPAs may cause cancer, carcinoids, and apprehension. That also put aside. Another thing is the prokinetic drugs have taken a center stage in the last 20 years. Prokinetics are gastric motility controllers, gastric motility inducers like etioprid, levosulfide, domperidone. And these drugs, they thought they have a big role to play, but their role is at best in only selected conditions, not a very wide application. Combining PPI should not be done with the anti-H2RAs like ranitidine. So you cannot combine omeprazole and ranitidine. I have seen several prescriptions. They prescribe omeprazole in the morning and ranitidine in the night. I do not know what logic is there in doing that. Science does not agree for that. Okay. Remember, one thing that can make a big difference is smoking. How does smoking cause dyspepsia? It hastens gastric emptying and then it decreases the pancreatic bicarbonate. That means the alkali is less, acid is not neutralized, decreases the duodenal pH, reduces the mucosal blood flow, inhibition of the mucosal prostaglandins, and relaxation of the lower esophageal sphincter. That we will see a little later. Now, I'm going to the algorithmic approach. What is this algorithmic approach? You see, the first step is, am I dealing with dyspepsia? What is that? There must be upper GI symptoms, relation to food, at least 4 weeks duration, relieved by antacids. That is classically a picture of dyspepsia. The symptoms of dyspepsia, heartburn, belching, burping, bloating, retrosternal pain, all that I have told you, it should come to my mind when you come to your mind when I say symptoms of dyspepsia. Okay, the patient has some dyspepsia. Then what should I do? Are there alarm signs? What are alarm signs? Mad blow. What is mad blow? Mass in the upper abdomen, A, anemia, D, dysphagia, BL, blood, either in the vomit or in the stool, LOW, loss of weight, unexplained loss of weight. If they are present, we are in for trouble, and the patient should get immediate upper GI endoscopy as early as possible. If there is a bleed, on the same day. If there is no bleed but loss of weight, anemia are there, within the next week you have to do the endoscopy. Okay. There are no alarm signs. Another patient is there who does not have mad blow. They are safe and we are not in any grave danger, but then age is a factor. What is the age of the patient? He's more than 55. He must go for endoscopy and no empirical treatment in people who are above 55. Okay, if the patient is less than 55, and you can call it as undiagnosed dyspepsia, UID, okay, uninvestigated dyspepsia, and start on empirical treatment. What did you understand? Patient comes with upper abdominal symptoms of dyspepsia. What are the symptoms of dyspepsia? Again, I have to show you that slide. Okay. Abdominal pain, bloating, nausea, early satiety, burping, borborygmi, acid regurgitation, heartburn, epigastric pain, burping, water blast. How long? At least for 4 weeks. And pain related to food. Okay? If these are there, we are dealing with a case of dyspepsia. Then the immediate next question is, are there alarm signs? What are alarm signs? Mad blow, mass, anemia, dysphagia, blood, and loss of weight. No alarm signs, no worry about endoscopy immediately. Okay? If there are alarm signs, endoscopy in the next 3 or 4 days within the 1 month. Supposing the patient is having bleeding, same day endoscopy. No alarm signs, more than 55, less than 55. More than 55, in spite of not having alarm signs, within a week or so, we indicate upper GI endoscopy because we don't want to miss cancer and also ulcer disease. Less than 55, no alarm sign, go ahead. You can empirically treat as uninvestigated dyspepsia. Then what is the second step? Okay, I have got a patient who is less than 55. He has no alarm signs. I can treat him as uninvestigated dyspepsia empirically with proton pump inhibitor. And not responding, I test for the H pylori. This is treat and test. This is one option. Or you can test and treat. Both are allowed. This is the usual practice. Treat and if not resolving, test. Because patient did not have alarm signs and he is less than 55, the chances of malignancy are small. Chances of ulcer disease also is small. And I would institute empirical treatment and then test if necessary. Okay, what is the third step? Patient who has got alarm signs or who is more than 55 years. Then review all medication, particularly NSAIDs and other drugs also. Suspend the NSAID and then order upper GI endoscopy. Classify the dyspepsia and into different categories and treat. If there is a bleed, same day endoscopy. Fourth step, UGI endoscopy has been done, then it can fall into one of the 4 categories. If you see an endoscopic report, you have to ask the endoscopist to mark the patient into one of the 4 categories. Otherwise, the report is not acceptable international. They can't say there is some erosion, there is this, there is that, some vague description not fitting. They can write anything in the description. At the end, is it non-ulcer dyspepsia, NUD? Is it chronic gastritis? 2 conditions, NUD and CG. Non-ulcer dyspepsia, chronic gastritis. Or is it GGRD? Or is it peptic ulcer disease, gastric ulcer and duodenal ulcer? Is there malignancy? So the endoscopist should put the patient in one of the 4 boxes. NUD-CG box, GERD box, PUD box, and then GI cancer. Why? The treatment is absolutely different for all the 4. Okay. This is the fourth step in the algorithm. And now, let us say we have done an endoscopy. We got the picture, uninvestigated dyspepsia. We have not done the endoscope, empirically treated, not resolved. We did an endoscope, GERD, peptic ulcer disease, non-ulcer dyspepsia. And then here also chronic gastritis. And of course, we have eliminated carcinoma and taken it away from our discussion because management is totally different. And functional dyspepsia, uninvestigated dyspepsia, GERD, peptic ulcer disease, both DU and GU, and then NUD and chronic gastritis, functional dyspepsia. The left out entity is carcinoma of the stomach, carcinoma of the upper GI tract, which we have separated because the moment we are suspecting malignancy, the route we take for treatment is biopsy and other management. So I'm not going to touch upon. Now I'm going to manage all these things one by one for you. Okay, what are my goals of treatment? Relief of pain, prevention of complications, and minimize the recurrence. Of course, what are the complications? Bleeding is one complication, obstruction due to cicatrization, fibrosis, and perforation of the ulcer. Bleeding, perforation, and obstruction. The common being bleeding, obstruction, perforation is the next level. So that is why I need to treat. What are my goals of treatment? Relieve the pain, prevent the complications, and minimize the recurrence. And bleeding, perforation, and obstruction are the complications which I will be looking for. Then what are the treatment options I have? What is the armamentarium I have? I have lifestyle changes. What are lifestyle changes? Reduce weight, stop smoking, stop the offending drugs, stop the offending foods, left side, and then raise the foot end. Minimum 2 hours after the food. These are the important lifestyle measures. Again, I'm going to show you that slide because you don't forget the lifestyle measures go a long way. So these are called the general measures, lifestyle advice, healthy eating, weight reduction, no smoking, avoid precipitant foods like coffee, chocolate, fatty food, and alcohol, raising the head under the bed, left lateral position, main meal at least 2 hours away from going to bed. And these are the general measures. So I instituted the general measures, then I have to treat with the specific measures. So what are the specific measures? Lifestyle measures, lowest efficacy. They are required, but they are not sufficient. Then antacids might relieve or antacids plus lifestyle. This is commonly what the patient practices. He may not practice lifestyle. He takes antacids. Maybe he will cut some weight or whatever it is. This is after a preference dent in 2002. Yes, clear. And I have marked here an asterisk. There is no clear benefit of prokinetics. Today's watchword is do not use the prokinetics left and right because they can affect the electrical conductivity of the heart and the more harmful than beneficial. All the same, use them only whenever it is whenever they are required, use them in the right dose and the right duration. Or H2RA, histamine 2 receptor antagonist. Histamine has got histamine 1, which is for the allergy and all the skin things you use. Histamine 2 is in the stomach. Histamine 2 receptor antagonist, ranitidine, famotidine, cimetidine. These are the various drugs of the H2RAs. Then the next level will be prokinetic plus ranitidine. Then once daily half dose PPI. What is half dose PPI? 40 milligrams of omeprazole is full dose. 20 milligrams is half dose. And this is the half. Okay, double dose be 40 BI. So there will be full dose, half dose, and double dose. So this is full dose PPI, then the double dose PPI. So that is the efficacy, lowest lifestyle, then antacids, antacids plus lifestyle. Prokinetics, not always useful. Be careful about the cardiac problems. And with or without H2REAs, without H2REA or H2REA alone or a combination, then half dose PPI and full dose PPI and double dose PPI. I take omeprazole as the prototype. 40 milligrams of omeprazole is full dose, 20 milligrams OD is half dose, 40 milligrams BID is the double dose. Okay. Now I'm treating one by one, starting with the uninvestigated dyspepsia. Who is this? This is a fellow who is less than 55 who did not have alarm sign. So I didn't do an endoscopy. Straight away, presumptively, empirically, I started treating. What do? I review the medication and stop all the offending drugs, common being NSAID. I institute all the lifestyle measures, weight, smoking, sleeping position, 2 hours after meal, offending foods and all that. That is lifestyle. Then I give him 1 month of full dose PPI, which is equivalent to 40 mg of omeprazole. 1 month. Then reduce it to PPI or H2RA for 1 more month. If not relieved, and even then not relieved, then go for the endoscopy. This is the protocol. So non-ulcer dyspepsia, sorry, UID, uninvestigated dyspepsia, patient less than 45, no alarm signs, empirical treatment, review medication, stop offending drugs, particularly NSAIDs, institute lifestyle, start full dose PPI, 40 milligrams of omeprazole for 1 month, then either continue PPI for 1 more month or shift to H2RA for 1 month, not relieved by 8 weeks or 2 months, patient must go for endoscopy. Okay, then NUD, you did an endoscopy and the report came as NUD or chronic gastritis. Patient may write, the report might read chronic gastritis or non-ulcer dyspepsia. There is no ulcer, there are patchy erosions here and there, looks like gastritis, that is the picture they give. CG, chronic gastritis or NUD, again, reviewing the medication, lifestyle is essential. Then what do? Non-ulcer dyspepsia can be due to H. pylori. I treat the patient, test the patient and treat the H. pylori. Okay. And after the treatment of H. pylori, which I will discuss in the next few slides, low dose PPI, that is half dose PPI or H2RA for 1 more month and no repeat endoscopy because non-ulcer dyspepsia can never turn malignant. Okay, only once in life. The patient will ask, sir, please do endoscope and again see. Not required, not at all indicated. For non-ulcer dyspepsia, no repeat endoscopy. When there is PPI you give and the symptoms are persisting, then low dose PPI you continue for some time and you give self-care, what is called on demand, PPI on demand. You ask the patient after 2 months of non-ulcer dyspepsia, you take as and when you have this. So PPI on demand or persistent symptoms, low dose PPI, self-care. So how do I treat NUD? Medication review, lifestyle, test for H. pylori, if positive, treat for it, low dose PPI for 1 month, no repeat endoscopy, persistent symptoms, continue with low dose PPI on demand also. Then you must know a little bit about GERD. For that, I'm going to take you through the lower esophageal sphincter. As you can see, this red big sac is your stomach, and this is the gastroesophageal junction. Okay, and these are the two crura of the diaphragm. The crura of the diaphragm will hold the lower end of the esophagus. Between them, like there's an opening, the diaphragmatic crura from all sides will be encircling the esophagus. And there is a gastroesophageal sphincter. This sphincter, it controls the movement of food by one direction. It does not allow the stomach contents to go back into the esophagus normally. That is the function of it. The sphincter is to allow the food passage from the esophagus down into the stomach and not regurgitate back. That holds it. But lot of air is generated here. This air during your digestion has to be expelled. For that, the lower esophageal sphincter relaxes just for a few seconds in a minute, maybe 4 or 5 times in a minute for 2 to 3 seconds. Total of around 8 to 10 seconds, the LES relaxes and allows the gas. This is a big mixie. In the mixie, churning is going on. When the churning is going on, the air is generated. For the air to escape, lower esophageal sphincter is competent to release for a small while. That is called the transient relaxation of the lower esophageal sphincter. Transient relaxation of lower esophageal sphincter is a physiological mechanism to let out the air in the stomach. Okay, but what happens in GERD? This transient is replaced by persistent relaxation of the lower esophageal sphincter, so much so gastric contents and acid reflects into the esophagus. Now, once the pH is less than 4, 7 is the neutral pH, less than 4 is a very acidic pH, and Savory Miller grading, stage 0, 4%, 6%, stage 1 and 2, 12%, stage 3 and 4, 18% of people in GERD, they have pH less than 4 in different stages to that tune. So you have to always give drugs to elevate the pH above 4. That is why you give antacids and anti-acid secreting drugs. Okay. The spectrum of GERD earlier days used to call as esophagitis, peptic syndrome, Barrett's, adenocarcinoma. Now we don't classify them like that. New paradigm is there erosive disease? That is called ERD, erosive reflux disease. There is no erosion, non-erosive reflux disease and complicated reflux disease, stricture and Barrett. Okay, is it erosive reflux disease, non-erosive reflux disease, or stricture and Barrett? Where do I look for this thing? In the esophagus. These are the changes in the lower esophagus, lower 1/3. So what are the extra esophageal manifestations of GERD? Very commonly asked question as a short note. When you are asked about GERD, you should write extra esophageal manifestation. Somebody is coming with persistent cough. I have many patients who had persistent cough, used antibiotics, lot of cough mixtures. I treated the GERD, cough has gone. Posterior laryngitis, laryngeal stenosis, frequent aspirations, and uncontrolled asthma and unexplained sinusitis are all due to extraesophageal manifestations of GERD. You treat GERD, sinusitis gone, asthma controlled, aspirations reduced, laryngeal stenosis reduces, laryngitis goes down, persistent cough vanishes. Now, complications of GERD. What can happen with the GERD? Esophagitis, inflammation, peptic stricture, that is acid stricture, Barrett's esophagus, I'll show you some pictures, esophageal ulceration, upper GI bleed, and adenocarcinoma of the lower esophagus, which is a rare but very important complication of GERD. What are they? Esophagitis, peptic stricture, Barrett's, ulceration, upper GI bleed, adenocancer. Now, this is Barrett. You see, this is the gastroesophageal sphincter. And the epithelium here is, in the epithelium here in the stomach is different from the epithelium that is there in the esophagus. Okay, there is columnar epithelium, squamous epithelium. There is a squamous metaplasia of the columnar epithelium here. that metaplasia is seen as the Barrett's like that. You can see very severe Barrett's esophagus. This can lead to, this is called erosive disease, ERD, and this can go to stricture, and this can also produce adenocancer. Okay, Barrett's esophagus should be immediately identified and GERD treated. Barrett's esophagus regresses, the epithelium again reverts back to the original one. Why this happened? This part of the esophagus is not tuned to receive acid. But once the acid starts coming into the lower esophagus by the persistent relaxation of the esophageal sphincter, TRELS is replaced by persistent lower esophageal sphincter relaxation. That results in Barrett's, and it can lead on to adenocarcinoma and stricture. Okay. What is the treatment of GERD? Lifestyle, very important. Full dose PPI for 2 months. You see, earlier we were giving for 1 month, we give for 2 months, and not relieved, you double dose PPI for 1 more month. Okay, then you add a prokinetic, not in the first place. Full dose PPI 2 months, not relieved, increase the dose to double dose, which means 40 milligrams of omeprazole twice a day, or 20 milligrams of pantoprazole twice a day, or 10 milligrams of ilaprazole twice a day. Different drugs have different dosages. Prototype omeprazole we take and talk about full dose, half dose, and double dose based on the omeprazole. Prokinetic medication has to be added. What are prokinetics? Domperidone, isopride, levosulpride. These are the things. The problem with them is the cardiotoxic. Then after 1, 2 plus 1, 3 months over, then H2RA, ranitidine, famotidine, or a prokinetic is continued for 1 more month. Okay, there are 4 months gone. There is no response. It is not GERD. Diagnosis has to be reviewed. Number 4. Low dose, supposing better, but symptoms are improved, still persisting, maintenance treatment, return to self-care with antacids. This is the protocol. GERD requires a vigorous treatment compared to NUD. Here, 2 months of full dose PPI, then 1 month of double dose PPI, addition of prokinetic, then 1 more month of H2RA or prokinetic, then low dose maintenance and self-care antacids. What is H. pylori? Okay. Helicobacter pylori is an offending bacterial infection of the stomach, upper GI tract. There are 3 tests. One is called the urea breath test, fecal antigen test, fat test, serology, IgM and IgG. The differences are accurate, costly, cannot be used in pregnancy, availability is questionable, it is used for both diagnosis and follow-up, and treatment affects it. C31 labeled isotope is used in the urea breath test. I will describe that. Fecal antigen test is very simple. Give the stool sample and then test for the antigen, acceptable, diagnose and follow-up, treatment affects it. Whereas serology, CORD test, ELISA, they are not for treatment, has no effect, and these are not for follow-up, only for the diagnosis. We'll see a little bit about urea breath test. So what we have to do, off antibiotics for 4 weeks, off PPI for 2 weeks. Stop PPIs for 2 weeks, no antibiotics for 4 weeks. Let the H. pylori grow, and then overnight fasting is done. We give C13, carbon 13 labeled urea 1 capsule is given. What will happen at 0 time? The patient swallows, let's say 8 a.m. or 9 a.m. He swallows the capsule. At the end of 3 minutes, he takes 20 ml of lukewarm water. The capsule dissolves and the urea there is broken down and comes as nitrogen. That one is labeled, carbon dioxide. Nitrogen, the carbon dioxide produced out of that metabolism, it comes out as radioisotope. In 10 minutes, patient take a deep breath and holds for 10 seconds. Like that, 10 seconds. Then exhales through a straw into a balloon. And the sample in the balloon is analyzed for the carbon in the carbon dioxide. Test is positive if C13 is present in the carbon dioxide. If the H. pylori are there, they break down the urea into carbon dioxide, and carbon dioxide comes in the breath. If H. pylori are not there, the urea capsule is not broken down into carbon dioxide. It goes as nitrogen, and urea breath test will be negative. So the pathogenesis of ulcers now, aggravating factors, acid, pepsin, bile salts, NSAID is H. pylori. Defensive mucus, bicarbonate, cell renewal, prostaglandins, phospholipid, free radicals, these are all. There's a tug of war going on between the protective factors, defensive factors, and the aggressive factors. And the outcome of the tug of war decides whether the patient will be protected or he will develop ulcer disease. Now, ulcer disease. How do I treat? Lifestyle. Very important. Test for H. pylori because majority of the people with ulcer disease are H. pylori positive, urea breath test, stool antigen, or an antibody, IgM antibody. Then H. pylori eradication treatment for 2 weeks, followed by PPI, full dose PPI for 2 months, then 1 month. So first you give full dose 2 months, see symptoms, not regressing 1 more month. So this is around 2 weeks, and this is again 3 months, total 3.5 months gone, and 2 weeks here, and then total 3.5 months. Then you give stop NSAIDs, decrease the dose. Selective drugs may be used like COX-2 inhibitors. Gastroprotection can be offered by misoprostol, which is used as an abortifacient in your gynec practice. Misoprostol, 200 micrograms into 4 days, is the gastroprotection. And then you have repeat UGI after 8 weeks to see if the ulcer has healed. And non-healing ulcer can turn malignant. That is why repeat endoscopy is required here. There is no repeat endoscopy for non-ulcer dyspepsia, chronic gastritis, or GERD. There is a repeat endoscope for ulcer disease. Now, treatment of PUD, stop NSAIDs, duodenal ulcer, 95%, 70% of gastric ulcers are associated with H. pylori. Treat the H. pylori, stop the NSAID, okay? And then GU repeat endoscopy and retest for H. pylori. Retesting duodenal ulcer usually not required. Consider low dose PPI as required for relapse. Now, what is about H. pylori? Word about H. pylori, Helicobacter pylori, gram-negative, spiral-shaped flagellate bacilli. They look like that under the microscope. And what do I give? This has got full dose PPI BID, that is 40 milligrams of omeprazole BID plus clarithromycin 500 milligrams twice a day plus amoxicillin 1 gram or metronidazole. This is available as combination HP kit, or some other kits are also available. It will have a PPI full dose, 1 clarithromycin, 1 gram of amoxicillin or 400 metronidazole in the morning. The same thing is repeated in the night. Combi packs improve compliance. How long I give? 14 days. Usually 10 days and maximum 14 days I give. So non-healing peptic ulcer, you have to consider the following things. One, non-compliance patient has not taken the medicine or is smoking. Ulcer turning malignant, it's not healed. H. pylori is resistant to the drugs you use, or it is a false negative H. pylori you got. So then you empirically treat the patient for H. pylori. And inadvertent NSAIDs or ulcerogenic drugs are being used. Rare causes, Zollinger-Ellison syndrome, MALT. And this is again the Crohn's disease and multiple endocrinopathy 1. Okay, multiple endocrinopathy. One, MALT is a sort of lymphoma of the GI tract. Okay, lymphoma, MALT lymphoma, the GI tract, and then you have the Zollinger-Ellison syndrome, Crohn's disease. These are other rare causes. Remember, non-healing peptic ulcer, patient has not taken the medicine. 2 is smoking. And 3, probably his ulcer is turning malignant, or the H. pylori is resistant for the drugs you use, or the false negative result of the H. pylori, in which case you empirically treat for H. pylori. Inadvertent use of ulcerogenic drugs like NSAIDs, and rarely non-healing or peptic ulcer, maybe urinary syndrome, a tumor which hypersecretes the acid there, and then through the stomach, and then lymphoma of the GI tract, malt, Crohn's disease, and multiple endocrine neuropathy. One, okay, and one. Then we are left with functional dyspepsia. What is functional dyspepsia? There is no ulcer disease, non-ulcer dyspepsia is not there, no chronic gastritis, no GERD, no malignancy, no peptic ulcer, no gastric ulcer. Patient still complains, I'm having pain. What is that? Something wrong here. That is the functional dyspepsia. Reassurance and lifestyle. Majority today, 20% of people are having functional dyspepsia. Behavioral counseling, acid suppression, prokinetics, antidepressants are very important to treat these people. Okay, what are the medications which can cause ulcerogenic medications or dyspepsia medications? Okay, low dose aspirin, 75 milligrams, somebody is taking for cardiac reason, no problem. NSAIDs, steroids, oral, not inhalations. Inhalation do not produce. Theophylline, any type. Bisphosphonates used for treating, hypercalcemia and other calcium metabolic disorders. Calcium antagonists, anticholinergics. So NSAIDs, steroids, theophylline, bisphosphonates, calcium antagonists, that is, CCBs, calcium channel blockers, and anticholinergics. Immediately suspend the medicine or reduce them to the minimum dose. Use selective COX-2 inhibitors like celecoxib. Then what are the future therapies? Potassium competitive acid blockers, CC2K receptor antagonists, that is cholecystokinin 2 receptor antagonists, anti-gastrin vaccine, and new PPI is already there, elaprazole, pantoprazole. They are once a day PPIs, and immediate release formulations are approved. H2REs are OTC medications like antacids. Now, ranitidine is purchased like an antacid purchased across the counter. Okay. Now, if you use PPI, this is the healing rate. If you don't use any, this is the healing rate. If you use ranitidine, that is the healing rate around 60%. Use PPI, 95%. The healing rate in around 8 weeks time, 8 to 12 weeks. So PPIs are better option for healing rates of ulcers. Now, a little about the acid secretion mechanism. This is the parietal cell which produces the acid. There is what is called the K-ATPase pump. What does this do? This takes one K inside and releases one H into the lumen, and this goes into the fundus of the stomach. That is the acid. But what are the stimuli? One is the acetylcholine, which increases that. Histamine, this also increases acid secretion. Gastrin, that also increases. Histamine through the somatostatin cells also, through the ECL cells and through the somatostatin cells. And this is the blood vessel in the antrum. And there are the D cells and the G cells. The D cells secrete a factor called somatostatin, which suppresses the G cell, and gastrin is suppressed. In the absence of D cells, the absence of less of somatostatin, gastrin is produced. Gastrin is a stimulator of the parietal cell. So, anti-gastrin drugs, H2REs, that is ranitidine. These are the anti-parasympathetic drugs, like atropine, like F drugs, and these also ranitidine. These act by various mechanisms. But the final common pathway is the proton pump. What is the proton pump? It accepts one potassium inside the and secretes one hydrogen into the canaliculus, which leaks into the fundus as the acid. And these drugs, proton pump inhibitors, they block that. So much so, whatever may be the mechanism, the final common pathway is blocked. That is why PPIs are a wonderful treatment. Now, which PPI? Pantoprazole, lansoprazole, meprazole, rabeprazole, esomeprazole. Duration of action. Hours with pH less than or pH more than 4. Less than 4 is dangerous, we know. So these are long-acting drugs, esomeprazole and rabeprazole, whereas these are twice a day you have to give. Now, time trends in UGI and carcinoma. Upper GI carcinoma, 1930s, 2010 have decreased very much, whereas adenocarcinoma, because of Barrett, is increasing, and also small cell carcinoma is also coming down. What is increasing now? The cancer trend, adenocarcinoma, not the carcinoma of the stomach or the SCC. Now, how do we miss cancer? The question is 2.8% of the patients or 3% have cancer, 25% of them have no alarm symptoms. They come very late. Alarm symptoms, only 8% have cancer. Endoscopy is not used appropriately. H. pylori is not considered at all. We do not review medications. Some ulcer medications until late stage we use, patient will be using for different painkillers. Alarm signs are missed and no urgent endoscopy has been done. And they say, give me only tablet and I don't want endoscopy. Give tablet and no endoscopy. Okay, in local language it is written. Matrai kudunga, give tablet, pipe vendam, don't put the pipe. Means what? That tells that patient's reluctance to get the endoscopy. You ask anybody, endoscopy. No. X-ray, take. Scan, you take. Endoscopy. But you have to convince the patient. Now I'm summarizing. This is the summary slide. Okay. Uninvestigated dyspepsia, non-ulcer dyspepsia or chronic gastritis, GERD, PUD, DUR, and functional dyspepsia. This slide doesn't contain cancer because that is not today's presentation. So what do I do? Full dose PPI, 1 month, H2RA, 1 more month, upper GI endoscopy, if not relieved. Then NUD, most of it is due to H. pylori, test and treat, low dose PPI or HRA for 1 month, no repeat endoscopy, please. GERD, full dose PPI, 2 months, double dose PPI, 1 month, prokinetics may be given, or H2RA plus prokinetics, or if not responding at the end of such vigorous treatment review. Then what happened? Only prokinetics have role, only here, nowhere else. You can see. Prokinetics have a role only in GERD. And then when there is ulcer disease, most of the people are by H. pylori positive, you test and treat. Okay, full dose PPI, 2 months followed by 1 month full dose PPI. If necessary, NSAID should be cut. Mesoprostol can be used. You repeat the endoscopy to see whether the ulcer has healed or not. This is the kind of case where you repeat the endoscopy. This is the case where you don't repeat the endoscopy. Functional dyspepsia, then you have to give antidepressants, H2RAs, and and antacids, H2RAs, antidepressants, and behavioral treatment. This is the summary of dyspepsia. I'm coming to the last slide probably. So there is a paradigm shift in the understanding. I promised you that I'm going to give you the new thing. Earlier, no acid, no ulcer. Now it is not like that. Acid, pepsin, and decreased defense. Very curry hypothesis. Obesity, decreased LES stone, fats, and smoking. Fractional test meal, berry meal series for the common investigations when we were students. Now, esophageal manometry, pH meters, urea breath test, antacids were the only treatment. We don't have H2RAs or PPIs. Now, PPI, H2RA, limited role for antacids. H. pylori not considered. H. pylori is the culprit. PUD carcinoma stomach is more. GERD functional dyspepsia, adenocarcinoma, the lower esophagus are more. NSAIDs are not considered. NSAIDs are central for the ulcer. GJ vagotomy is the common operation. Here, no surgical treatment for today's dyspepsia, except for hiatus hernia. GI surgeons have changed their jobs because There is no need for surgery except in hiatus hernia. A long way we came from antacids to antibiotics to treat your H. pylori. Okay. Points to remember. Remember the alarm signs. Age more than 55. Empirical UID treatment. UGI for diagnosis after 8 weeks. PUD always test for H. pylori. Eradicative treatment. GERD, you have to double the treatment, strong treatment. No long-term PPI. NSAIDs are important. If not responding, review the diagnosis. Repeat endoscopy only for the ulcer disease. Prokinetics only in GERD. Self-care after cure. This is a beautiful saying from Saint Kabir. जब मैं था तब गुरु नहीं, अब गुरु है मैं नहीं, सब अंधियारा मिट गया जब दीपक देखा मैं. What does it mean? When my ego was firmly in me, जब मैं था, मैं means the ego. The God has no place. Guru nahi. Now, ab Guru hai. Now, I am the abode of the Almighty. My ego has no place. मैं नहीं. सब अंधियारा मिट गया. All the darkness, illusion is driven away. When the inner light of wisdom is brilliantly lit in me. जब दीपक देखिया मैं. A beautiful thing. It transcends any religion. And this is a beautiful words from Saint Kabir. Okay. Now, I will show you the pictures. These are the esophagogastroduodenoscopy called the EGD. Some people call it as upper GI endoscopy, UGE. And traditionally in Western countries, it is called EGD. So this is endoatlas.com. I acknowledge with thanks the pictures from endoatlas.com. No commercial interest, only to show the students. This is the normal corrugated rugosity of the stomach. You see the folds of the stomach so beautiful. And then you see. And these are the rugosities, close-up view of the normal stomach. Okay. And this is a sac. No, when you fill with food, it will expand. For that, the rugosities are there. Okay. Now, Candidiasis of the esophagus. Very common in HIV infection, in diabetics, and people who are on chronic NSAIDs and you had ulcer disease. They can also have, and who are on steroids, immunosuppressive medication. Candidiasis of the esophagus, white, curd-like, or yogurt-like flaky appearance on the lower esophagus. This is also candidiasis of the esophagus. You can see, like the on the top of the milk, there will be a sort of settled milk will be there, the cream, and like that, cream-like thing on the esophagus. Then severe GERD, multiple ulcers, very rough and looks a very eroded esophagus. And then chronic GERD, the Barrett's already changes are there. You can see that there is, this is acute severe GERD, usually alcoholic or any other reasons. Chronic GERD, the columnar epithelium is replaced by squamous metaplasia, and that is the chronic GERD. This is the Barrett's esophagus. This picture you have already seen. These are chronic changes in the esophageal mucosa, which can lead to either stricture or adenocarcinoma of the lower adenosine. It can come. Now you see there is a retained tablet in the esophagus due to narrowing. The tablets are retained and patient is not able to push it into the stomach. And it's very common with chronic stricture of the esophagus. Adenocarcinoma, you see, this is the adenocancer part of the esophagus, a complication of chronic GERD. NSAID ulcers, this is called salt and pepper appearance, sprinkled appearance. the NSAID ulcers. Okay, these are also NSAID ulcers. Very common to see that. These are in the stomach. Now, H. pylori ulcers. This is the typical salt and pepper. As if somebody has sprinkled salt and pepper, again in the stomach, fundus of the stomach, and the greater and lesser curvature in the body of the stomach. These are the typical H. pylori ulcers, all four pictures. Now you see the gastric ulcer. So this is a slough also there in the ulcer base. Okay, gastric ulcer. Gastric ulcers previous days were very many. Now peptic ulcers are more. Now gastric ulcer with a lot of slough there, and this one is also a gastric ulcer, as you can see here. And then duodenal ulcer. That's the duodenal ulcer there. And this can go on to stricture, obstruction, and complications are, what are the complications? Bleed, obstruction and stricture, and then turning malignant cancer are the complications of duodenal ulcer. That's why whenever we treat ulcer disease, at the end of 8 or 12 weeks, we have to read an endoscope, confirm that the ulcer has healed. Adenocarcinoma, huge mass at the lower end of the esophagus, a very extensive adenocarcinoma of the stomach. And carcinoma of the stomach, you can see this is a huge carcinoma of the stomach here. And here also the ulcerative carcinoma of the stomach. Okay, this is a normal mucous membrane. Okay. My dear learned intellectuals and stalwarts of the society, please beware. Whatever you practice is being keenly observed by the common men. They take you as a benchmark and will simply copy whatever you do. So the onus is very much on you, sirs, to set yourself highest standard to be a role model.
Thank you so much, Professor Dr. Sarma VSN Rachakonada, sir, for your nice presentation. I hope our honorable guests here tonight, our medical students and our new young doctors, those learned a lot about dyspepsia. And dear audience, I would like to again thank you for your patience hearing, for being here with us, for being here with our mentor, Professor Dr. Sarma VSN Rachakonada, sir. He is an MBBS, MD Internal Medicine, MSc Canada, FCGP, FICP, FIAMS, FIMSA, FCCP USA, FACP USA, FRCP, and he is an emeritus professor of cardiology, Rajiv Gandhi Institute of Medical Sciences, RIMS, Andhra Pradesh. Our mentor is also consultant physician, Manipal Hospital, Bangalore. Our sir is an adjunct faculty of JSS Ahar Medical College, Mysore, and he is an adjunct professor, Tamil Nadu, Dr. MGR Medical University, Chennai. He is also online faculty for MSCP training, Texila American University, Honorary National Professor of Medicine, IMSCGP, and he is also former Secretary, American College of Physicians, India chapter. I would again like to thank Dr. Sharma for your honorable time and for your so much gratitude towards us young doctors. You gave us, sir, so much time. You gave us your knowledge and you shared your knowledge with us. And I hope our young doctors will be benefited towards your knowledge. And I would also like to thank MediSchool for arranging such sessions for our young doctors. And also I would like to thank our partner here today, our scientific partner in Incepta Pharmaceuticals, for being our scientific partner here tonight. So sir, we are at the end of our session. Before leaving us here tonight, we would like to say some words to our sir, and thank you again for your time, for your kind gratitude to ourselves, and I would like to again see you with us here in another session. Would you like to say some words to us, sir?
Nothing. I enjoy talking to you, but I wonder whether there are any questions to be answered. If you have any questions, I can take up.
Sure, sir. Let me check. We have few questions, probably not for the panelists, but from the audiences. So let me check. I can get to you some questions.
Thank you.